This is the topic of discussion today is infertility. So this will be discussed on these headings. How do you define infertility? What is infertility? Could be the causes of infertility, and what are the investigations we will suggest for the couple to find out the cause, and what kind of management we can afford. So, from our definition is failure. Is failure to conceive. That does not mean it is inability. Failure to conceive after 1 year of regular unprotected coitus. So, this is 1 year should pass before the person is stamped as failure to conceive or infertility. 1 year must pass, and they must have regular unprotected intercourse. Not that with the contraception using, then they are some 6 months of using contraception, they are coming and I am not able to conceive. So it must be 1 year before you start an investigation. So usually the male and female are both responsible, the 40% and 40%, and both will be 10%, where both the male and the female are responsible. Some defect in female, some defect in male, they are very difficult to treat and unexplained. Number of situations we will face where all investigations, standard investigations rather, the common investigations rather, reveal that there is no problem, but still the couple is not having any conception. So that is unexplained infertility. So from our knowledge of physiology of conception, we know that for the conception to occur, we must have mature motile sperm, we must have mature ovum discharged from the ovary and released into the peritoneal cavity, and which should be picked up by the fimbria and will be moved to the ampulla, where the sperm from below moves and the fertilization occurs at the ampulla. This is knowledge you have already from the physiology of conception. So we will concentrate on these 3 areas, whether sperms are motile, normal or not, and how much is the number, whether the ovum are releasing regularly or not, and whether the patent genital tract, especially patent tube is there to pass the sperm to the ampulla, and whether the ovum is picked up and moved by the tube into the ampulla. So these are the 3 important areas: sperm, ovum and patent female genital tract, where we will concentrate our investigations. So first, always we investigate a male, because the investigation of male is only a simple thing, that analysis of semen sample, that is called semen analysis. So from there we can know the pathology is there or not. The causes, if we find abnormality in semen, the causes could be either in the testis, or if the testis is normal, because of the obstruction at the vas deferens, it cannot come into the urethra and cannot, we do not find the sperm in the ejaculate, and whether the seminal vesicle and prostate has the important part to contribute to the sperm for its motility especially and nutrition. So nutrition comes from the seminal vesicle, and prostate gives the prostaglandin for motility of the your sperm, and whether the pituitary function is there to release FSH, which is important for stimulating the spermatogenesis from the seminiferous tubules that you all know, and even after that the ejaculation may not be via the urethra, but may go retrogradely to the bladder because of the sphincteric defect, and whether there is, because of erectile dysfunction, because of the erectile dysfunction, the sperm cannot be deposited. In spite of having the semen analysis normal, it is not deposited in the vaginal pharynx. So, the sperms are not available for fertilization. So, these are the problems which can occur with the female, with the male. And so, what kind of sperm abnormalities we face? So, it is maybe sperm count is low. We will come to that, how much is low and how much is normal. We will come to that when we talk about the semen analysis. The low sperm count, there is a name for the low sperm count, you know, this is oligospermia, oligospermia, no sperm, azoospermia, dead sperm, that is because it is motile, so you do not know it is living or not. So, dead sperm is necrozoospermia or necrospermia, abnormal sperm morphology, that is teratozoospermia, and agglutination of sperm, that is because of anti-sperm antibody in the male. So, these are the abnormalities we find in the semen, and so we can find out the cause. Talking about the semen analysis as per the latest standard, a volume should be more than 1.4 ml and sperm concentration is more than 16 million per ml. This is concentration, total sperm count is different. So, it will be about 30 to 30, around 30, if you use 1.4 and if you multiply, total motility must be more than 42%. And progressive motility, that is very important, not only motile, it is forward motility, it must be more than 30%. And morphology, minimum morphological normal sperm will be more than 4%. If it is 14% usually normal, but it has been seen that it is possible to have conception if it is more than 4%. So, that is about the semen analysis. Further analysis, fructose must be present. It is contributed by the seminal vesicle and provide nutrition to the sperm. Leukocyte concentration must be less than 1 million. If there is more leukocyte, that means there is infection of the prostate and seminal vesicle, giving the toxic things which causes the problem with the sperm. So, leukocyte must be low, and semen during the analysis, semen should reach the laboratory within 1 hour of collection if it is collected at the home, but if it is collected at the laboratory, then question does not arise. 2 to 3 days abstinence before semen sample collection. So, it will be advised to the couple to have 3 days abstinence, and then examination to be repeated after 4 weeks if one find the abnormality in the sperm. So, finding the abnormality once does not mean that there is abnormal semen analysis, but you have to repeat it after 4 weeks. So, that is about the semen analysis. Then, how to investigate a male. So, you know, the investigation involves the history taking, examination of everything. So, important finding the history is the occupation. Working in the hot environment hampers spermatogenesis. Like working as a driver near the engine, working near the furnace, they all causes the low sperm count, and then it is the smoking and alcoholism that all hampers the spermatogenesis. Some drugs also, whether they are taking some cytotoxic drug, antidepressant, antibiotic, so many drugs are there, some antihypertensive also, which could cause low sperm count. Further investigation on examination of the testis, you may find varicocele by clinical palpation of the scrotum, which can raise the scrotal temperature, thereby hampering the spermatogenesis. Not always, but sometimes it has been found. And testicular abnormality may be there, testis may be small or testis may be undescended, that means intra-abdominal. These are the things which by clinical examination can be detected as a cause of semen abnormality, sperm abnormalities in the semen. And surgery on scrotum, if there is history, that can damage the vas deferens, causing obstruction in the vas deferens. Even there may be vasectomy operation also, so that is one of the cause. So that which causes the abnormal semen analysis. And laboratory investigations, we all know FSH and testosterone is responsible for spermatogenesis. So FSH may be high, may be low. If it is low, the defect lies with the pituitary or hypothalamo-pituitary axis. Number of causes are there. If FSH is low, definitely the serum testosterone will be low. Interstitial cells of Leydig cells secrete the testosterone, and TSH, prolactin, sugar, all are important for spermatogenesis, so that all investigations should be done. Come to the vasogram. So where FSH is normal but spermatogenesis is abnormal, that is a situation. That means FSH is normal but sperms are not coming. That means there is obstruction. In that case, the find out the cause of obstruction or site of obstruction, we need to do vasogram. And testicular biopsy, usually not done, but somebody may do it to find out whether there is atrophy of the seminiferous tubules or not. So if it is found that seminiferous tubules are not atrophied, there are some sperms so which can be retrieved by testicular puncture. So that is a special technique, and so testicular biopsy is done for that purpose, but usually not done. And karyotyping, if you suspect Klinefelter syndrome, so that is a case where there is abnormalities of the semen or sperm. Then treatment. So if this is the abnormal, it is in the sperm, whether it is, how can you treat it? So general instruction here in case of infertility, general instruction, it is general instruction, the coitus should be around the days of ovulation, not on either side, so that, and consecutive 3 cycles. If the semen is normal and we do not find any other cause, so this is the general instruction given to the couple, that around the days of ovulation and consecutive successive 3 cycles, not that the one cycle they have tried, but in other cycle there is not again another cycle. So if there is scattered intercourse or scattered conjugal life, so that is not helpful for conception. So change of occupation, that is very important, and that means what environment is to be changed. Stoppage of offending drug. These are the general instructions given to the male person and couple. And if there is these things are all right and semen analysis is abnormal, then possibly and if there is no obstruction in the vas, of course, even if there is obstruction, anastomosis of the vas will not be much helpful. So alternate way of treating the semen, of treating the male infertility, is artificial insemination, AI. AI is not a very difficult procedure, it is not a complex procedure. So artificial insemination, it may be either by husband semen or by donor semen. Donor semen, where there is azoospermia, so in that case there is no other way to collect the semen from another person, that is donor. Of course, the donor should be matched with the ethnic population. Astheniospermia, that cannot be treated, cause is mostly unknown. So asthenospermia and genetic disorder, because that genetic disorder may pass to the offspring. So in that case, we will suggest not the semen of the husband, but semen from the donor is to be taken, which must be screened for genetic disorder. So artificial insemination by donor. And by husband, oligozoospermia. So sperm count is low, but it can be concentrated by centrifuged machine. So that is the way you can get the concentrated sperm, motile sperm especially. So oligozoospermia is an indication for artificial insemination with the husband. And unexplained infertility, where there is no cause, in that case we concentrate on ovulation and insemination. So pushing of the semen or spermatozoa in the uterine cavity around the days of ovulation. So in that is unexplained. In case of unexplained infertility, it is helpful. And anti-sperm antibody, if it is there within the cervix, not in the male, if anti-sperm antibody is found in the female, so to bypass, to skip the cervical mucus, which is where antibody is present, so we go for directly insemination into the uterine cavity, bypassing the cervix. So that is one of the treatment by artificial insemination in case of anti-sperm antibody. Now, other treatment for antibody is not much helpful. That's why we go for a success rate with this artificial insemination is not bad. It is more than 30% or like that. Coming to insert artificial insemination, principles are maybe fresh semen, maybe frozen semen. So either may be there, and sperm count must be more than 5 million per ml. If it is less than 5 million per ml, then the artificial insemination is not going to help. Then washed and centrifuged in specific media, the sperms are centrifuged and drawn in a plastic catheter, flexible catheter 0.5 ml, which should contain more than 1 million motile spermatozoa. So if less than 1 million spermatozoa will not be helpful for artificial insemination. So concentrated spermatozoa will be more than 1 million. So and introduced in the uterine cavity via cervix. So that is the principles of artificial insemination. Then you come to the, and it should be put in the uterine cavity 36 hours. With the natural cycle, you can go for artificial insemination, but there is more success if it is cycle is stimulated by HCG injection, and around the dose of ovulation 36 hours after the HCG injection, we will come to that later on. There is ovulation. So on that day, for 2 days, 1 day's interval of successive 2 days, we can go for pushing of the concentrated semen, concentrated sperm within the uterine cavity, and consecutive 3 cycles. Success rate is 40%. She may conceive by 1 cycle, if not next cycle, if not next cycle. So consecutive 3 cycles, if it is not successful, then you can say that failure of artificial insemination. That is about male infertility. Coming to the female, we know ovum is there, must be there, and be discharged around the days of on the day in the mid cycle, and one patent tube must be there to pick up the ovum and for passage of the sperm up to the ampulla. So tubal factor we must examine, because cause of kind of abnormality of tubal factor may be blockage of the tube due to salpingitis. Number 1. Number 2, salpingitis also causes damages of the ciliary process. So that is important for carrying of the ovum towards the ampulla. So by salpingitis, both things are damaged, and salpingitis also causes peritubal adhesions, which hampers the tubal peristal's tubal motility. So tubal motility is hampered by peritubal adhesion. So these factors are there or not. So there is a way to detect it. We'll come to that later, in how the tubal factor is assessed. Then ovulation, whether it is occurring regularly or not, number of causes of anovulation is there. We are not going to discuss that, but test for ovulation, we must be assured that whether ovulation is occurring regularly or not at the middle of the cycle. So that test will suggest to confirm whether the ovulation is occurring. So confirmatory tests for ovulation we will go through, and cervical factor may be thick cervical mucus and anti-sperm antibody. These are the cervical factor. Uterine factor may be fibromyoma, maybe intrauterine adhesions that you know that is called Asherman's syndrome, and peritoneal factor may be endometriosis, may be tuberculosis. That we by investigation we have to find out whether the defect is at the tube, whether the defect as the ovulation, whether the defect is at the cervix, whether there is problem with the uterus, or whether the problem is within the peritoneal cavity, that means endometriosis and tuberculosis. Ultrasonography of pelvis, this is a non-invasive procedure that you can easily do in a female to find out whether there is SOL, that means uterus a fibromyoma or not. Though fibromyoma more causes abortion, this is especially if it is submucous than infertility, but it may cause infertility also. Ovary, whether there is chocolate cyst, that indicates endometriosis. Whether there is polycystic ovary, that is a cause of anovulation. So by USG you can know so many things. TO mass, tubo-ovarian mass, that arises from the pelvic infection chapter you have been taught. So TO mass, tubo-ovarian mass, pelvic infection and hydrosalpinx you may find by ultrasonography or by other tests, we will come to that. So that means there is infective causes there or not. So that is ultrasonography is one of the investigation for the female, and that should be the first investigation rather. Then you come HSG, hysterosalpingogram. Possibly it has been taught to your small group lecture classes, those who have attended know. The HSG will be plate, X-ray plate will be given in your practical examination, and so how HSG is done will be taught in details there. The dye used is iodine containing dye, radio opaque dye, Conde 420 or Conde 320, and it is done, very important, it is asked in the exam, when you will do to from 7th to 12th day, because after 12 days there is chance of ovulation and conception, so that it is not disturbed, and after 7th day, so menstruation is over, so endometrium is epithelialized, so there is no chance of invasion of the drug to the endometrial veins in 7th to 12th day, and no anesthesia is needed here with the hysterosalpingogram that is done in the department of radiology. So you have to go there and push the dye through the cervix, and they will do the take the X-ray, state X-ray following your pushing of the dye. So what is the advantage and what will you see? Site of blockage can be known. Whether the blockage is at the fimbria, whether the blockage is at the cornu, or whether the blockage is at the middle part of the tube. So that depends on how much dye you are pushing from the below, and dye is moving through the tube, so how much distance it has traveled. So that is the area of site of blockage. And cavity of the uterus, that is an extra advantage. If there is filling defect, that means either it is intrauterine adhesion or it is a fibromyoma, that can be seen also, and it is a permanent record. And spasm, disadvantage of is because it is not under anesthesia, spasm of the tube at the cornu may appear as blockage. So this is apparent blockage, that is not a real blockage. So we can go for the, this is the picture of HSG that will be given, plate will be given on your practical examination table. You see, this is the size of, this is the uterus and this is the tube. The dye has moved there and there and there. So there is, here is spillage of the dye. The dye is there and there is spillage of the dye. There is spillage of the dye within the peritoneal cavity. You see, till there is a shape of the dye, tube, uterus, that means there. But if it was stopped there, that means Fibian blockage. If it is stopped here, that means cornual blockage. If it is stopped here, dye, you cannot see beyond that. That means it is that blockage at the middle part of the tube. And this is the cervix, and this is the instrument through which, that is called cannula, that has been shown to your instrument likely, Leach-Wilkinson cannula, through which dye is pushed. So that is the plate of HSG. Then another test, and that is the gold standard test for the patency of the tube, and that must be done in every case, that is laparoscopic dye test, or it is called laparoscopic chromoperturbation dye test. What is the dye used? It is methylene blue dye, not the Jensen violet, not any other things, because those dye are irritant and cause peritoneal adhesions. So methylene blue is inactive, so that is not cause such things, and because it is done under anesthesia, so there is no question of spasm factor, there is no question of apparent blockage. So methylene blue and dye pushed into the uterine cavity via cervix. Patient is under anesthesia, so it is done in the OT. So HSG is done in the radiology department, but this is done in the operation theatre, and dye appears in the POD. If you find the dye in the POD, so how the dye you find? Because it has come through the fallopian end of the tube, that indicates that tube is patent. So at least one tube is patent. If you find the dye in the pouch of Douglas, that means at least one tube is patent. Which tube is patent and which tube is blocked, the details you can see with the help of laparoscopy, but appearance of dye is patent tube, and usually done in the luteal phase of the cycle, not like HSG, which is done in the follicular phase, usually done in the luteal phase of cycle. Why in the luteal phase? Because this is the picture, this is the dye. So this is the dye, and this is the bladder, and this is the uterus, this is the fallopian tube and femoral end, and this is the femora, and this is the appearance of dye. So this is the picture of laparoscopic chromotribution. And so advantage, so why it is done in the luteal phase of the cycle? Because diagnostic curettage is done at the same sitting. Why the diagnostic curettage? Because by diagnostic curettage, you can send the endometrium for histopathological examination to find out the signs of ovulation. So by seeing the secretory changes in the endometrium, you know there is ovulation, number one. Number two, you can also find out the corpus luteum, that also indicates ovulation, and at the same time tuberculosis and endometriosis. You can see the tubercles on the outside the tube, that means tuberculosis is diagnosed. Endometriosis, that means powder bud appearance, that is also diagnosed by the laparoscopy. So not only tubal patency, these are the diagnostic, at the same time diagnostic advantage with the laparoscopy, and patency of the tube and peritubal pathology, whether there is peritubal adhesion, that is not possible to see by HSG, but by laparoscopy you can see, even if the tubes are patent, dye is there, but if there is peritubal adhesion, that is the cause of infertility, because it hampers the tubal peristalsis, which is very important, very much important for sending the fertilized ovum, fertilized egg, your morula, to the endometrial cavity. So that is peritubal pathology is also assessed, and at the same sitting you can go perform the surgeries. So it is not the diagnostic laparoscope, it is at the same time operative procedure. So nowadays in case of infertility, we don't go for any diagnostic laparoscopy, we always keep the instrument for surgeries ready, we keep the expertise for the surgeries ready to go for adhesiolysis, peritubal adhesion. Endometriosis can be treated also by cauterization, and if you can combine the hysteroscopy along with the laparoscopy, in that case intrauterine adhesiolysis could also be done. So these are the advantages of laparoscopy. So these are the advantages of laparoscopy. A hysteroscopy, that is a procedure to find out the endometrial cavity especially, and but that is not for the hysteroscopy, is not for the tubal patency, for the evaluation of endometrial cavity. But if there is Asherman syndrome, it can be diagnosed and adhesiolysis could be done, and usually combined with laparoscopy if somebody likes to do. And if there is submucous myoma, that can be operated also with the hysteroscopy. And most important thing is, if there is cornual block found with the HSG, you can go for hysteroscopic cannulation to overcome the block. Hysteroscopic cannulation to overcome the block, it is successful, then its success rate is 60% or like that. In 60% cases, there will be conception. Hysteroscopic cannulation. That's why a hysteroscopy is also a procedure for investigating a female for infertility. Another test for tubal patency is saline infusion sonography. Saline infusion sonography, SIS, saline infusion sonography. About 200 ml of saline is put into the uterus and through the Foley's catheter, and the catheter is inflated to cause block at the cervix so that it does not come out. So imaging of uterus is done by the ultrasonography, TVS rather, and uterine cavity, because the uterine cavity is distended, it is better visualized by uterine cavity, and movement of fluid through the tube can be visualized to the peritoneal cavity. So that is also by ultrasonography you can test the tubal patency also. Otherwise it is relatively non-invasive. So nothing is required. Only on a radiology department you will be called to put saline with the help of the Foley's catheter, and they will do rest of the thing. By that you can know so many things about the tube and the uterus. So saline infusion sonography, in short SIS. Then come to the test for ovulation. One is for folliculometry. Folliculometry is a serial ultrasonography. So you have to monitor the size of the follicle. Suppose on the 10th day you find the follicle 10 millimeter. Then on 12th day you find the 12 millimeter. Like that you go on serially monitoring the size till it is 18 to 20 millimeter. So 18 to 20 millimeter follicular size means at this time there will be ovulation, follicle will rupture, causing rupture of the follicle. Or next day if you go for ultrasonography, you will find that there will be no follicle like that, such a large size. That means follicle is collapsed. So that is a test for ovulation. So by this you can know which day the ovulation is occurring. That is very important, because you have to advise the couple to go for the coitus on that conjugal life on that day. LH detection kit. You know the LH surge is there, luteinizing hormone. So LH detection kit is available from the urine. So LH surge, if it is detected at the urine, so ovulation takes place after 36 hours. So to advise the couple to undergo the conjugal life on that day and the next day. So only 2 days conjugal life is enough to have the pregnancy or conception, because ovum only is fertilizable in the genital tract for 24 hours. 24 hours. So by 24 hours, your spermatozoa must be available for conception. Then is a diagnostic curative. So if already we have stated that around the days of on 21 days of menstruation or 7 days after ovulation, if you study the endometrium, if it is found secretory, that means ovulation has taken place. If it is found proliferative, that means ovulation has not taken place. So finding the secretory endometrium when the DC is combined at the time of laparoscopy, so tubal patency as well as the ovulation, both the tests are done, can be done or confirmed. Tubal patency and ovulation can be confirmed at the same sitting. But days of ovulation you do not know unless you go for LH detection kit or serial folliculometry. And serum progesterone, if it is found more than 10 nanogram on 21 days of a 28-day cycle, more than 10, that means double figure, double digit, then it indicates the ovulation. So, these are the tests for ovulation. Clinically, these are the confirmatory tests that we have mentioned, that is everybody has to advise those tests and to interpret the results. But some clinical tests are there. Before we advise those invasive tests, laparoscopy and all those things, one may know considerably from this test, that is basal body temperature, BBT, fall and rise. On the day of ovulation, there will be fall of temperature followed by 0.5 to 1 degree rise. That means if somebody goes on taking the oral temperature daily after menstruation, they will find the thing like this. So you see the temperature is going that like this, diurnal variation, and there is ovulation, there is drop of temperature, then there is rise. So then, and it will be raised for the next of the phase because of progesterone effect. So this is basal body temperature. So by that time, patient herself knows at home that this is the day on which they have to concentrate for their conjugal life to have the conception. So that is basal body temperature. Next you come to the farming of cervical mucus. So you know the cervical mucus, there is farming because of the estrogen effect, and with the progesterone effect, the consistency of the cervical mucus is changed, and there will be disappearance of farming if you put the cervical mucus under the microscope. So appearance and disappearance of farming is the proof that there is ovulation. So many other tests are there. These are the two important tests, and you see the farming. This is the farming appearance of cervical mucus, and when it will disappear, that means appearance is disappear, that means it is progesterone effect, that means ovulation is there. So we have by the test we have understood the test for ovulation and test for patency of the tube. So how to usually that tubal patency treatment is not much satisfactory like semen abnormalities, but which is satisfactory for treatment is if there is ovulation, lack of ovulation. So there are so many drugs available to induce ovulation. So what are the drugs? We must know induction of ovulation. Clomiphene citrate, very commonly used, is a drug. Side effect is very, very less, and it is to be given from day 2 to day 6, 50 to 150, and if with the 150 milligram, means 50 milligram thrice daily from day 2 to day 6 for consecutive 3 cycles, if there is no ovulation which is detected by the tests we have already described, that means there is clomiphene resistant. So clomiphene resistant cases, you have to give some other drugs for induction. So conjugal life 5 days after last clomiphene. So ovulation takes place 5 to 10 days after 5 to 10 days after the last clomiphene. So if it is taken from day 2 to day 6, so ovulation will take place on day 11 to day 18 or like that. So you have to advise the couple to concentrate the conjugal life on those 6 to 7 days. So that will give successful conception. So conjugal life 5 days after last clomiphene, and letrozole is another drug aromatase inhibitor, which causes estrogen synthesis less. That means estrogen is low, and that indicates rise of FSH and LH, which causes ovulation. This is another drug which is now recognized, which is now recommended for at the same day 2 to day 6 for induction of ovulation. The rest of the advices are same. Then if it is not successful, we can go with the metformin with clomiphene, especially in cases of PCOS, polycystic ovarian syndrome. So polycystic ovarian syndrome, so many treatments are written in the books, but for ovulation induction, it is the main purpose. Why we will treat a cycle? Because ovulation is needed for conception. So PCOS with infertility is more important. So in that case, metformin is the drug which sensitizes the insulin synthesizers, which causes ovulation. But if simple metformin is not enough, it is combined with clomiphene to have more success with the ovulation induction. So that is very important. And clomiphene followed by, or it may be clomiphene followed by injection FSH to stimulate the follicle, Suppose there is no further progress after 11 millimeter, 12 millimeter. If you give FSH, so it will come to 16 millimeter or 18 millimeter. So, or like this, if you give a 5000 unit FSH, there will be ovulation. So clomiphene followed by FSH, another regime. So many regimes are there, details of which is not necessary to know. But this is another where clomiphene is failed clomiphene, that means with the 6th cycle, injects your FSH 3 to 10 days, or FSH and LH combination, that is called human menopausal gonadotropin, HMG, human menopausal gonadotropin, FSH LH combination, that you can give from 3 to 10 days. When you find that follicle has grown up to 12 or 16 millimeter, then you can give 5000 injection of LH or HCG, to for ovulation. So monitoring a follicle and injection HCG 5000 unit at 18 millimeter size. So this is the principle of induction of ovulation. After a certain period, you have to stimulate the cycle with FSH or LH, FSH and LH, and by HCG. So that is the principle of induction of ovulation. Now, what could be the followed by 5000 unit at 18 millimeter size follicle, and side effect is ovarian hyperstimulation, because you are stimulating the ovary epithelial activity that could cause excessive enlargement of the ovary, giving rise to the pain and serositis, and giving rise, that is called ovarian hyperstimulation syndrome, OHSS, ovarian hyperstimulation syndrome. That is a side effect. And so if it is not successful with our FSH, LH and all those things, you can try with ovarian drilling. That means surgical treatment, not nowadays very commonly. Previously it is used to do, but nowadays we do not do. Laparoscopically it will be done. So this is another advantage of laparoscopy. Multiple puncture 4 to 6 is done by diathermy on the ovary. That causes the hormonal milieu to change and will cause the ovulation. So it is only effective for 6 months. So if the patient fails to conceive within 6 months, it will not be effective further. So that is about the ovulation induction. This is few lines about ovarian hyperstimulation syndrome, side effect of ovulation induction. That is usually the side effect of FSH, LH, not the side effect of clomiphene. Usually we rarely find ovarian hyperstimulation with the clomiphene. So clomiphene is a very safe drug. A risk factor for ovarian hyperstimulation is PCOS. So the clinical picture is pain, abdomen, distension, respiratory distress, oliguria, serositis is the cause. More with the gonadotropin injection, treatment, admission may be necessary, and supportive care means IV fluid and all the supportive care needed. Surgery is usually, though there is ovarian enlargement, surgery is usually not needed. That is about the treatment of ovulation. We will come to the treatment of the tubal blockage, and treatment operation on the tube is called tuboplasty. Tuboplasty, operation on the tube, that if there is fimbrial adhesion, so that you have to separate those fimbrias, that is called fimbriolysis, or with other adhesions around the tube, with the peritoneum, with the intestine, or with the uterus, that is called adhesiolysis. That all these things you can do by laparoscopy. That is the advantage of laparoscopy. You can do so many things. Fimbriolysis, adhesiolysis, hysteroscopic cannulation, that could also be done at the ostia, at the cornu. Success rate with the tuboplastic operation is less than 20%, because you are establishing the patency of the tube, but you may not, you may not be able to establish the ciliary function is that of the tube. So that's why the success rate is low. Success rate is low. Not only that, there is chance of ectopic pregnancy. So success is for anastomosis following tubectomy. If somebody has undergone tubectomy for sterilization procedure, but if she changes her decision to undergo further pregnancy, for that if she want to establish the tubal patency, in that case, because there was no pathology, tubes are intact, in that case tubal reanastomosis is effective, and effective about 50% of cases. So this is about tuboplasty. This is the reanastomosis with the tube. If there is blockage, you have to cut the blocked part, and by the 80 vicryl, you have to anastomize the tube with 4 or 5 sutures, and with the mesosalpings with the sutures. So that will cause re-establishment of the patency. Epithelium is grow from this side to that side, and there will be establishment. But there is chance of stricture at this level causing ectopic pregnancy. So that is about the reanastomosis. For the uterine factor, you can advise do the myomectomy for submucous fibroid. That could be done by hysteroscopy, as I have already mentioned. Cervical factors, due to amputation of cervix, cauterization and stenosis, all these cases, we can go for dilatation. I have already mentioned in all these cases, the procedure is artificial insemination. It is a procedure for the conception to artificial insemination of husband. AIH is a treatment. AIH is a treatment. What about unexplained infertility? No abnormality found with the semen analysis, with the tubal patency, with the ovulation. Ovulation is confirmed by the test, tubal patency is confirmed by HST laparoscopic, semen analysis shows the sufficient motile spermatozoa, that means 16 million per ml, that is the concentration. So that is called unexplained infertility. Investigation, you can go for only one, only post-coital test or Simpson test, that is rarely done nowadays, but this is the test. Cervical mucus is collected after coitus, usually 4 to 6 hours of coitus. Within coitus, cervical mucus is collected, examined under microscope. If less than 10% motile spermatozoa is found in the cervical mucus, that indicates that possibly cervical mucus abnormalities is there, antibody is there, and motile. Suppose some sperms are there, the sperms are not motile, that means sperm antibody is there, anti-sperm antibody. So that is one of the tests for unexplained infertility. Anti-sperm antibody, no man's blood, In that case, so we go for artificial insemination with the husband is a treatment. So artificial insemination with the husband is a very important procedure. That is not in fact artificial assisted reproductive technique, not the ART. AIH is not assisted reproductive technique, which will come later slides. ART. What do you mean by ART? The procedures involving isolation of the ovum. So we have to handle the ovum and manipulation of the sperm and ovum. Unless we handle the ovum, it will not be called ART, assisted reproductive technique. In vitro fertilization and embryo transfers is a commonly procedure done and success rate is very good. The principles are ovarian hyperstimulation controlled. So when few follicles have developed by the drugs, then you have to collect the ovum. 4 to 6 ovaries are collected and under TVS monitoring at 18 millimeter follicle size indicates ovum is mature. Then washed and centrifuged sperm concentrated prepare about 50,000 to 1 lakh sperm with the ovum put in the specific media, incubated in the specific media for 48 hours for fertilization and is transferred to the uterus with the endometrium with at the 4 to 8 cell stage zygote. So into the uterus after 72 hours, the 2 to 3 zygote are transferred usually, at least 2, because one is not survived, another will survive. That's why 2 to 3. And so, as you are transferring 2 to 3, so if all of them survive, there is chance of multiple pregnancy. So oral progesterone is given for endometrial suppose up to 14 weeks. So complications are multiple pregnancy, I have already mentioned. PIH because of multiple pregnancy or because of some immunological factor, that is a complications of artificial reproductive technique. Ovarian hyperstimulation syndrome, because you are controlling the ovarian cycle with the FSH, HCG, etc., and miscarriage will be there because you are transferring 2 to 3 or more. Success rate is 30% only. So out of 100, only 30 will be able to have pregnancy with this IVF ET, in vitro fertilization and embryo transfer. So if the sperm concentration as I have stated that should be more than 5 million for the artificial insemination to succeed. Because then you go. So this is the last slide possibly, and this is the that is the intracytoplasmic sperm injection. So that is how it is done. This is the surrogacy, and this is the summary is male person is investigated first. Laparoscopy is must for investigation of female. Treatment of tubal factor is unsatisfactory. IVF it is practiced most as ART procedure. Surrogacy is legalized in India. Surrogacy legalized in India. Thank you.